So now we're going to talk about common and expensive causes of malpractice suits. And for each of them, I'm going to try and hit for you those so let's go back. So on the because I'm going to start here. Okay, so now we're done with two sections. So for the first section, malpractice in the chart, that basically boils down to omissions. Is ascribe all of malpractice and charting boils down to omissions. If you omit something that the doctor asked or did to make sure somebody didn't have something serious, that can result in malpractice. So omissions, that green stripe, just think omissions. Step 2, the blue stripe. How does the doctor think? Differential diagnosis. So we've got omissions and differential diagnosis. That's what I want you to take away from so far. So for part 3, we're going to talk about high-risk chief complaints, things that cause malpractice. And what you need to take away from this is that as the doctor thinks through the differential diagnosis for each of these high-risk chief complaints, what is it important for me not to omit so that a lawyer knows that I thought about all of these things? Okay? So you follow in the big picture? Okay, so now that we've got the big picture, let's break down this next piece. Okay. So these are common and expensive malpractice suits. Common causes of malpractice are chest pain cases, because there's a bunch of horrible stuff that causes chest pain, and when people die from it, they're mad, or get hurt from it, or, you know, are short of breath the rest of their life because we missed it. They get mad. Okay? And then some other ones. Headache, orthopedic things, fractures, abdominal pain, psychiatric cases. And then expensive causes, these aren't frequent because there aren't that many sick kids, there aren't that many spinal cord injuries, but boy, when a kid gets injured or dies, boy, that's a lot of life, a lot of productive years that are lost. So that turns into a very expensive case. When you have a spinal cord injury, this tends to happen in young, active people, and they're blown in a tube to get around the rest of their life and need 24-hour care. Boy, that's 20 or 30 or 40 years of very expensive care. So those are very expensive. And then we'll just touch on a few other high-risk areas. So that's where we're going. So, I'm supposed to tick through these as I mentioned each of those. Okay? And these will be the visual cues as we go through those. So with no further ado, what am I doing here? So I just want to mention that, so if I was going to talk about the medical legal issues for any one of these topics, chest pain, headache, it's an hour-long lecture, and I have listened to some hour-long lectures on each of these preparing for this talk, and I'm going to breeze through each of them in 2 or 3 minutes. So this is a very abbreviated version of this, and please keep learning about these. And the second point I want to make is that the list of diagnoses that I give you for each of these that you need to be concerned about is not even the complete short ER list. I've picked out the ones where the main tool the doctor is going to be using to rule these things out of the differential diagnosis is the history of present illness and review of systems, the stuff you'll be documenting. So you're only going to see diagnoses that it's your job to make sure on every chart that it shows the doctor has thought about it. Mind reading, I know. Okay? So there are those 2 points. Obviously, I need to rehearse my graphics. Okay, so for chest pain, here is the ER differential diagnosis for chest pain. You'll see the 6 things here that I mentioned before as the ER differential diagnosis for chest pain. But I'm only going to emphasize the ones for which your documentation will be critical. So we're not going to bother ourselves with pericarditis with effusion or tension pneumothorax, because those are things that are going to be found on the physical exam and on the chest x-ray. So history of present illness isn't as important for those. So that leaves us with 4 things that you have to know your doctor's thinking about when they walk into the room with someone with chest pain. So we'll start with myocardial infarction. Okay, and here's Homer having his heart attack. He eventually has bypass and does fine. Okay. So you've got to document for myocardial infarction because this really can be all that your doctor does to prove a patient doesn't have myocardial infarction is know the risk factors for myocardial infarction, and you should be able to rattle these off. Probably just in your gut you know these, even if you've never memorized them. They're hypertension, high cholesterol, diabetes, smoking, and a family history of someone having a heart attack when they were young. So all 5 of those should be addressed on every chart, and I'm sure your doctors have been asking them. Hypertension, high cholesterol, diabetes. It's not enough to just circle them if they're there. You need to cross them out if they're not there. Okay? Smoking and early family history of MI. Secondly, some things that make you more suspicious about an episode of chest pain being something serious. If the patient becomes diaphoretic, if the pain is exertional, or if it radiates to the arms, either arms. Believe it or not, it's more likely to be a heart attack when it goes to the right arm than when it goes to the left. The left arm is more common. Those of you who understand statistics will understand how that's possible. Okay? So that's it for myocardial infarction. Okay? Now, the next one is thoracic aortic dissection. Okay? What that is when the biggest artery in the body rips open. Sound bad? It is. It results in massive blood loss, and the mortality is between 1 and 3% per hour that the diagnosis is delayed. So you're not going to live long with this if your ER doctor doesn't pick this up. Okay? And eventually every ER doctor pretty much is going to miss one of these, because there's only about 1 of these for every 1,000 heart attacks. So this really is a needle in a haystack. And we're not going to do a test for this on every patient that has chest pain, or else we would be ordering a CAT scan on every patient that walked through the door and be causing more cancer than lives we save from aortic dissection. So the doctor's questions most of the time will be the only test that they do to rule out aortic dissection. Therefore, it's vital that you record when the doctor asks the questions that point toward the diagnosis of aortic dissection. These questions are: did the pain start suddenly? Sudden onset pain is concerning because, the blood vessel started to rip. Okay. Secondly, does the pain radiate to the back? The way the aorta sits anatomically, frequently patients will get pain in the back. 3, has the pain changed location? Because as this thing rips, it hurts here, and then it hurts here, and it hurts here, and then it hurts here as it rips down. Okay? Fourthly, did the patient actually describe it as a tearing or ripping quality? It's odd that people can sense that, but it is common. And then finally, neurologic symptoms are important. Does the patient have numbness, trouble speaking, stroke-like symptoms? Because as the aorta rips, these vessels here are going to the brain. So if it rips and blood stops going up there, then they can get stroke-like symptoms. Okay? So that's it for aortic dissection. These couple slides you should study. Okay, we're on to number 3, pulmonary embolism. And we talked about this one a little bit already. What a pulmonary embolism is just a blood clot in the lung that prevents blood flow from going to the lung. If blood doesn't flow to the lung, it doesn't get oxygenated, you die. Okay? There's really one question directly in the history that points toward pulmonary embolism, and that is this pain pleuritic? Meaning, when the patient takes a deep breath, does it hurt? Now, there are other questions that also get us there. Is there any blood in the patient's sputum? But for pulmonary embolism, it's not so much the history that's important. It's the patient's risk factors, which we talked about a little bit. Have they ever had a previous blood clot? Has anybody in the family ever had a blood clot? Are they on estrogen? Have they had recent surgery, trauma, or cancer? Because all those make blood clots form in the vessels. Have they been flying because you're sitting in that cramped seat that's like being under anesthesia because you can't move? Or any other immobilization recently. So those are the risk factors. So when you hear patients accessing things that sound irrelevant, like, have you been flying? Are you on birth control? Those aren't incidental details for chest pumps. Those are actually vital to convey to the lawyer that I've ruled out pulmonary embolism because this patient has no risk factors. So don't blow these things off when you hear your doctors ask these things that seem possibly insignificant. So finally, the last really bad one is esophageal rupture. Okay, that's when your esophagus, the thing that connects your mouth to your belly, rips. Okay, and it rips almost always when people are vomiting. Okay, so if the patient hasn't been vomiting, this is very unlikely. So if the pain didn't start during vomiting and the patient hasn't been vomiting recently, it's unlikely the patient is going to have this, but you need to make sure that those are on the chart. So that is it for chest pain. So with chest pain, one of the biggest pitfalls and things that leads to lawsuits is a specific but unproven diagnosis. Beware of this. So when a heart attack is missed, the most common thing that's written on the chart is GERD, reflux. Okay? Just write chest pain. It's better to say to the lawyer, to the jury, to the patient that we don't know what's causing your pain. It sounds like reflux, but there's no way I can prove that. You have chest pain. This could be serious. You need to come back if you're getting worse. Okay? So beware the specific but unproven diagnosis. That would be musculoskeletal chest pain, GERD, so forth. Okay? Just write chest pain. So that's it. And that's one of the longest ones. So it'll go faster from here. So next, orthopedic stuff. And we're going to talk about fractures in this poor squirrel. So for fractures, a patient's occupation matters. And it will matter how you treat a patient, depending on what the patient's job is. Say a construction worker or a chef who cuts off the tip of their finger is going to miss a few days of work and their career is going to be unaffected. However, a concert pianist, a surgeon, or a hand model, that could be the end of their career. Okay? So that's important that you've documented, okay, this person who I didn't do anything for the tip of their finger, send them home, because that's what we do for 99% of these, is not going to have their career ended by that decision. Okay? Secondly, handedness matters for the same reason. Somebody who loses the pinky finger on their non-dominant hand is not going to have the same disability as if they lost that on their dominant hand. Okay? The next thing that's important with fractures is I want you to learn, and basically all orthopedic stuff, is I want you to learn this little mantra. And just go over it in your head, over it in your head. It's joint above, joint below, sensory motor vascular, skin and compartments. So joint above, joint below, sensory motor vascular, skin and compartments. If I could come up with a dance for it, I would. Okay, because that needs to be addressed on every orthopedic chart. Joint above, joint below, sensory motor vascular, skin and compartments. Okay? Learn it. Alright. So let's talk about what I mean by that. So joint above and joint below. It's because when you experience enough force to break a bone, that force can be transmitted. So we have a little bone fracture right here. It's actually hard to see. But that force is transmitted up the fibula and you get a fracture all the way up here, almost up at the knee. Okay, so there's an ankle. This is almost up at the knee. There's a number of other injuries where this can happen. So we're frequently not going to x-ray the knee for an ankle sprain. But you have to document the patient doesn't have any pain in the knee. Okay? And the same thing with further down the foot. Alright? So secondly, sensory motor vascular. So as you can see in this graphic, nerves, yellow, arteries, red, veins, blue, all run right along the bone. So if you have a broken bone, it's very likely that one of these could be injured as well. We have to document they are not. Because a broken bone, you put in the cast, you send home, they see orthopedics. If you have a ruptured artery, Your arm dies if you don't fix that. If you have a ruptured nerve, you may never move that limb again if that's not fixed. So that makes this a much higher risk thing. So if you haven't documented that the patient has no nerve injury, no numbness or tingling, has good function and strength in the hand, or whatever the limb is, then you leave your doctor open to exposure if they have indeed checked those things. Finally, the skin, okay? If you just break a bone, it's just a broken bone, you put it in a cast. However, if that bone gets exposed to the outside environment, it gets exposed to bacteria, then you have a nasty infection of the bone. It's called osteomyelitis. And frequently, when a fracture is open, meaning the skin is broken, so bacteria can get in, that patient needs to go to the OR to have that bone washed out. So if you haven't documented that the skin was intact and the patient later has an infection, the lawyer's going to say that was the doctor's fault because they never looked at the skin. Okay? And then finally, compartments. This may be a new concept to many of you, this entity called compartment syndrome. But when you squish a limb, let's say squish this limb and there's a broken bone in there are these tight little layers of tissue called fascia. If those of you who are meat eaters, there's that tough, like, it's almost like a sheet of slippery white stuff you'll sometimes come across, like you'll find it in chicken. And that binds all the muscles. As you get swelling in the compartment, the pressure rises and rises because that stuff is really strong. And that swelling will eventually compress the arteries and you'll have no blood flow distally. So you need to document, and then really the doctor will be documenting that the compartments are soft. But the thing that you will need to document is that the patient having a tremendous amount of pain. That is an indication of compartment syndrome. The main symptom of compartment syndrome, which is where swelling compresses the arteries and nerves, is pain out of proportion to injury. You know how much a broken bone hurts. You've seen enough patients who are rolling around and holding their arm. If you see somebody whose pain is much worse than it should be, then that is a sign of compartment syndrome. So you should document the pain is appropriate for the injury, or something like that. Or patient with moderate pain rather than severe pain, or pain well controlled. Okay? And so that's it. Before we go on to this, joint above, joint below, sensory motor vascular skinning compartments. Every ortho chart. Okay? Headache. Okay, the next high-risk complaint is headache. We see a million headaches, and most of them are just migraines or drug seeking or who knows what. However, mixed in among these millions of non-serious headaches, there's a few serious things like tumors and meningitis and subarachnoid hemorrhage that will kill the patient if we don't catch it. And the nice thing is that we have a really good test to rule out most of the bad things, which is a CT scan. However, so the ER differential diagnosis for headache is actually pretty long. But CT scan is going to pick up almost all of this. However, there are two headaches that cannot be diagnosed by CT scan and for which a lumbar puncture, a spinal tap, has got to be performed. So we do have good tests to pick these things up. However, because, one, patients hate having spinal taps, and doctors really, to be honest, don't like doing them, the chart needs to defend the doctor's decision either to do or not do a spinal tap, because they're not just going to go doing spinal taps on everybody. So these two headaches are meningitis and subarachnoid hemorrhage. We do see subarachnoid on CT some of the time, most of the time, over 90% of the time, but about up to 10% of the time we don't see it on CT scan. So you have to do a lumbar puncture to make sure the patient doesn't have this. Okay? So you need to document enough that there's no reason to think this patient has meningitis. There's no reason to think this patient has subarachnoid hemorrhage, and that's why this doctor didn't do a spinal tap. Okay? So let's first talk about meningitis. Meningitis is basically an infection of the brain, and it looks gross. Okay? Not surprisingly, if you look at this, it has devastating consequences Many people die. Those who don't are permanently impaired. A few people go back to normal. Okay? So, important signs of meningitis are one, fever. So don't blow off that fever question in the headache. That is an absolutely key thing in the review of systems. Even though the doctors just go, have you had any fever, chills, nausea, vomiting, this and that, make sure you get that fever. Okay? I skipped. There we go. Secondly, does the patient have a stiff neck? Okay? Because it's not just the inflammation of the brain, it's inflammation of the meninges, which extends all the way down the neck around the spinal cord. So the neck gets stiff and hurts too. Thirdly, if your brain's infected frequently, you have altered mental status. Makes some sense. Infected brain is not going to work right, altered mental status. And finally, a rash. Just see these little blotches on the brain here? They form all over the body as well. So you need to document the patient doesn't have any of these things if a spinal tap is not performed. Okay? No fever, no stiff neck, no altered mental status, and no rash. So you might, you go in for a headache case and the doctor's asking about rash. Just make sure you don't miss it. It's actually critical. Okay? For subarachnoid hemorrhage, it's a somewhat shorter list. Subarachnoid hemorrhage is when a blood vessel in the brain bursts. There's blood in there. Eventually, blood expands and it crushes the brain because the skull is hard and can't expand. You die. It's bad. But this happens suddenly. Usually, this headache is sudden onset, and it is usually the worst headache that the patient has ever had. So, it is very important to document. If the doctor doesn't do a spinal tap, this is not the worst headache that this patient has ever had. If it is the worst headache that your patient has ever had, and your doctor's not doing a spinal tap, you should ask them how to document that on your chart. Secondly, sudden onset of pain. You should say that the headache is gradual onset. So that timing element that we're doing for the coders for headache should always address was it sudden onset or gradual onset. If we're not doing a spinal tap, it better be gradual onset. If not, talk to your doc. Okay? And I wanted to address kind of the special case that if the patient has a fever and a headache, because I know you've all seen 100 of these, because people get a fever, they're breathing out more water, they're sick, so they have a headache, and your doctor's not doing a lumbar puncture. Their only defense in court that he or she thought of meningitis is your documentation of that the patient didn't have a stiff neck, that their mental status was normal, and they didn't have a rash. Those three little lines can make a difference between no lawsuit and $1 million settlement. So, no pressure, okay? So, let's get them off, huh? Abdominal pain. So this is the third most common cause of malpractice, and missed appendicitis, as well as other abdominal catastrophes are the big players here. Part of why we miss appendicitis and other belly complaints so much is that there's not really anything specific that points to these diagnoses. And unfortunately, a CAT scan and an ultrasound can't detect everything bad that happens in the belly. So we don't have any perfect tests. And remember our three tools, like the history one. The history is always non-specific. Secondly, our tests aren't perfect, and our laboratories are not perfect either. So, abdominal pain can be looking for a needle in a haystack. There's a million things that cause abdominal pain. The vast majority of them aren't serious. We have to find that one that is. And the key thing, you'd have to spend, you either got to spend hours or almost no time on abdominal pain. So we're going to do no time because we don't have hours. So the one thing I'd like to emphasize to you for abdominal pain is that reevaluations, because bad things, for the most part, don't get better. So when your doctor goes back in and that belly's feeling better after some meds and it's still soft and no rebound, the doctor will be documenting that, but the patient feels better, they're not getting worse, that's a good sign. So make sure anytime your patient goes back and sees a belly pain patient, that you document a reevaluation. And we could spend hours on that, but that's all we're going to do. Oh yes, I forgot my humorous slide. It's worse than finding a needle in a haystack. It's more like finding a needle in a stack of needles. But anyway. Okay, so back pain. Anybody who's worked with me, I always talk to my scribes about this. But how many million cases of back pain have you seen? Back pain is very common. 50% of adults will have back pain at some point in their life, or it might be like 60 or 80%. I mean, some ridiculous number of adults are going to have back pain. I'll say all these drug seekers that have back pain, and so you know how this goes. You walk into the room, the doctor asks a few questions, they push on the patient's back, maybe tap on their knees a little bit and say, here's your ibuprofen and Percocet and muscle relaxer. See your orthopedist or primary care in the next week or so. However, this is another needle in a haystack situation. Lurking in the midst of all these low back pains and drug seekers is a smattering of patients with really serious or potentially deadly diseases. And you know from the 1,002 cases of these that you've seen, it's rare for us to do any tests. Most of them aren't even going to get an x-ray. So the main tool, really the only tool we use to find the lurking deadly diagnosis is the history. So this is all on you guys to document this, okay? So let's talk through these. There's 5 bad things that cause back pain, okay? The first is metastases, okay? Metastases is when cancer spreads to the spine, and this frequently can be the first sign of cancer. However, it's going to be excusable if we miss the first presentation of cancer in the back. However, if a patient has a history of cancer and we miss that their back pain is caused by metastases, that's a lawsuit. It deserves to be. So we need to document that this patient has no history of cancer. Okay, the next one is epidural abscess. This is when an infection forms around the spinal cord and grows like an abscess. You know, the abscess you see in the skin. Same thing happens in your spinal canal, except there ain't no room in your spinal canal. So this abscess crushes your spinal cord, and you never walk again. Okay? But because it's an infection, it's frequently going to have a fever. So in your back pain patients, you have to say they have no fever. It's frequently caused by drug abuse or other, because they are continually putting bacteria into their bloodstream, which flow around. It's stuck right here, and then it starts to form an abscess. If they have any other infection, a UTI, pneumonia, all that can get into the blood and get stuck right here and cause this abscess. Or if they're immunosuppressed for some reason, if they have HIV, diabetes, anything like that that makes their immune system not work well, their chance of this is much higher. So you need to document no fever, no drug abuse, no infections at this time, and if there is any immunosuppression history, it should be on the chart. Okay, the next one is cauda equina syndrome. This is when you've had some sort of injury to the back, or it can't even just be a disc pushing out. It actually crushes the nerve roots coming off the spinal cord. So the spinal cord actually ends pretty high up. That's why we do a spinal tap down here, because we don't want to hit the spinal cord. The spinal cord ends way up in the middle of your back. And from there, just some nerves trail off and kind of run down into your legs. Okay, and so this is a picture of that. If a disc comes out right here or right here, it crushes all these nerves that are coming out, and nothing below that works after that. So this patient may never walk again. They may be pooping on a diaper for the rest of their lives if they have this. So there's a few questions you need to ask, or a few things that need to be documented to make sure that the patient does not have this. And they are, has the patient had any loss of bowel and bladder control? Because the very last one of these nerves that comes off controls the sphincters of the rectum and the bladder. So if that patient, it's actually more common to have retention. So if the patient can't pee or can't poop, well actually, you can't pee and you are pooping on yourself. It's the most common presentation. Okay? So you have to document no loss of bowel or bladder control. Secondly, if they have saddle anesthesia, if they mention that they feel numb when they wipe themselves when they go to the bathroom, that's bad. Or if their legs are weak. If this is crushing higher up and it's getting some of the higher nerve roots, their legs will actually be weak. So you need to document basically no neurologic symptoms, which of this are loss of bowel and bladder control, saddle anesthesia, which is where a saddle will hit you, and leg weakness. All right. Third one is a kidney problem. I'll put this in black because it's white right now. So if they don't have UTI symptoms, the two things you need to get here, are there any recent UTI symptoms, or has there been any blood in your urine? And the fourth one is that pesky over the aorta again. Okay, and again, this is white. I need to make it black. So it shows up. But do they have a history of high blood pressure? Because that's the big risk factor for the aorta rip. Do they have pain that started somewhere else, like in their chest, and now they've got this severe back pain because they're infarcting their kidney? So what happens is that blood vessel splitting open, and then it splits open and cuts off the blood pressure, the blood vessel going to a kidney, and as that kidney dies, it feels just like sciatica, and then the patient dies too. So we want to make sure that the pain didn't start anywhere else. We'll miss this one most of the time, but if we can document that we at least thought about it, that'd be good. Okay, we're coming to the end of the common ones. So psych. Psych isn't so much hard as you just kind of get thrown off. So psych, the story's frequently interesting, especially the crazy people, the depressed people. It can kind of be, I don't know, you can kind of get into the story. But our job really isn't to get the psych person a story. If we want to be kind and compassionate, we can, and we try to. But our job is two things. If they're coming into the hospital or going home, is to medically clear them, to make sure that there's not some medical reason that they're having this. Their sodium isn't a million, or they have meningitis, so they're acting weird. So we need to document a good review of systems that indicates there's really no indication that this patient is sick in any other way. And then if the patient is going home, we need to document that they're not a threat to themselves or others. Okay? And that's basically it for psych. Make sure we're not missing something medical. Make sure they're not going to hurt themselves or others if they leave. Okay? Finally, okay, so now we're on to the expensive cases, which are pediatrics. Basically, for kids, we keep doing less and less testing in kids. So how a kid looks, the parent's impression of how the kid looks is key to whether we do testing or not. You know, a kid with a fever is 4 months old, or 3 months old, or even 2 months old, or if people are really brave, a little more than 1 month old, who comes in. If the patient doctor thinks they look perfect and the parents report they look perfect, the kids get no testing going home. Okay? And so it's really important to document that the parent thinks they look good. And this is just an example, but if your doctor's asking things that seem ridiculous, like, oh, is the patient is the kid making eye contact with you? Are they eating normally? Are they playing normally with their friends? All those little silly seeming things, document all of them. So some of those might be a non-toxic parent. The child looks normal to the parent. The child makes good eye contact, is interacting with the parents, is taking food and fluids, and is active. Okay? All right. Spinal cord injuries, and then we'll be done with this section. The long, painful section. Okay? So spinal cord injuries are bad, especially the higher up in the spine, the worse it is, because the less of your body works, the higher the injury is. So when your neck gets broken, for example, your cord gets crushed, it's one up there, and you end up like poor Christopher Reeve and so many other people who get around by blowing in a tube and need 24-hour care. Okay? Surprise, surprise. If we miss this, people sue, and for good reason, and we shouldn't miss this. Okay? So, the medics put patients in C-collars for good reason. So, if a patient arrives in a C-collar, it's important for us to document when it came off. Before X-ray, after X-ray, the patient took it off themselves. If we told the patient to keep it on, they keep taking it off, make sure we're documenting that. And there's criteria for removing a C-spine, removing a C-collar. Most patients who come in a C-collar do not need a neck X-ray. One of the best studies ever done was a a study called the Nexus study. You'll hear about it in medical school, but it gives us some criteria for removing a C-collar. So any patient that comes in a C-collar, you need to document, do they have alcohol on board? Do they have numbness or weakness anywhere else? And do they have severe pain anywhere else? That, if your arm has a bone sticking out of it, maybe you're not going to feel that neck pain. It's called a distracting injury. So it's a patient in severe pain somewhere else that might keep them from feeling the pain in their neck. That's the only indication they have a spinal cord injury. So those three things, or I should say four things. When did the collar come off? Did they have alcohol on board? Neurodeficits? Or do they have distracting pain? So that is it for this long, painful section. Waiting to stay with me. This next section has, I think, 10 slides, but they're each very quick, and we'll get through it.